So it's a pleasure to introduce our first panel of speakers for this morning's session. Dr. Jacqueline Cohen is a clinical psychologist, and she's also co-lead for the Central Zone Mental Health and Addictions Borderline Personality Disorder Treatment Program. She's also director of training for the Clinical Psychology Residency Program, and she actually is a founding and credentialed member of the Canadian Association of Cognitive and Behavioural Therapies. Dr. Dana Lee Bagley is a clinical health psychologist who works in the QE2 Health Sciences Center for the Multi-Organ Transplant Program, and also with Dr. Michael Vilas in the Behavior Change Unit. And she has a very active research program regarding behavior change and acceptance and commitment therapy. And Dr. David Whitehorn, who has a background in neurosciences, who I've been fortunate to know for many years as a result of his work with the Early Psychosis Program. He's director of the Atlantic Contemplative Center and has actually been practicing and studying mindfulness for more than 40 years. And I will now turn things over to our panel of presenters.
Hello, welcome, and thank you for being here. So it was a great first talk, and it set us up nicely to talk about the third wave's CBT that we're going to talk about now. So this is our financial disclosures. And we're going to start by actually doing a mindfulness exercise. And so what we're going to be doing is a mindfulness of the hand exercise for about 5 minutes. And what I'd first just like you to notice is, what does your mind predict about this? What kinds of things is it saying about having to do a mindfulness exercise about your hand? And if you can, just try to be open and curious and maybe treat it like a bit of an experiment about what it's like. So I'd invite you to get into a comfortable position and just turn one of your hands palm upward and hold it in a comfortable distance from your face. For the next few minutes, I'd like you to observe your hand as if you're a curious scientist who has never seen a hand before. And from that perspective, first notice the outline. Mentally trace the outline of your hand, starting at the base of the thumb and tracing around all the fingers. And notice the shapes of the spaces in between the fingers. And notice where your hand tapers in at the wrist. And now notice the color of your skin. Notice it's not just one color. There are different tones and shades and dappled areas. And ever so slowly, stretch your fingers out and push them as far back as they will go. And notice how the color changes in your skin. And then slowly release the tension and notice how the color returns. And do that once more, ever so slowly, noticing the color disappear and then return. And now notice the large lines on your palm. Notice the shapes they make, where they come together or diverge or intersect. And zoom in one of those lines and notice how there are many smaller lines feeding into it and branching out of it. And now shift your attention to one of your fingertips and notice the spiral pattern there, the pattern that you always see on fingerprints. And notice how the pattern doesn't stop in your fingertip. It carries down along your finger. And trace it right on down and notice how it continues into your palm. And now, ever so slowly, bring your little finger towards your thumb and notice the flesh in your palm scrunches up. And now slowly release. And notice the flesh resume its normal contours. And now turn your hand into the karate chop position. And notice the difference between the skin on the palm and the skin on the back. And look at your index finger. And notice there's a sort of dividing line where those two types of skin meet each other. And ever so slowly, turn your hand over. And notice the skin on the back. And notice any criticisms or judgments your mind makes. Notice any scars, sunspots, blemishes. And notice the different colors in the skin, where it passes over a vein or over your knuckles. And ever so slowly curl your hand into a gentle fist. And notice how the texture of your skin changes. And notice any comments your mind makes about that. And focus in on your knuckles. And gently rotate your fist. And notice the contours and valleys of your knuckles. And now tighten your fist. And notice what happens to the knuckles, to their color and to their prominence. Then ever so slowly open your hand up. Straighten your fingers. And notice how your knuckles just disappear. And now bring your attention to one of your fingernails. And notice the texture of the nail and the different shades of color. And notice where it disappears under the skin and the cuticle that seals it there. And now ever so slowly, ever so gently, wiggle your fingers up and down. And notice the tendons moving under the skin, pumping up and down like pistons and rods. And that brings us just to the end of 5 minutes. So thank you for participating. And just ask yourself these few little questions. Did your relationship with your hand change during the exercise? Did it change in a positive way? How would you describe it? Did it change in a negative way? What thoughts hooked you? So thank you for participating.
Good morning. So before we launch into a description of the various third wave or third generation cognitive behavior therapies, let's talk about what we actually mean by the term. In 2004, Stephen Hayes, who is the developer of Acceptance and Commitment Therapy, or ACT, proposed that there's been 3 successive waves of behavior therapy. He conceptualized each wave as evolving out of the previous one, resulting in many shared features between the waves. The first wave emerged in the 1930s, 40s, and 50s. This is what we think of as behaviorism. It emerged in response to the psychoanalytic formulations that focused on hypothesized unconscious fears and desires. In contrast to the analytic approach, behaviorists argued that psychologists should concern themselves only with observable events. Behaviorists viewed behavior as determined mainly by an individual's learning history, especially in terms of their experiences with reinforcement and punishment. So you probably remember a number of behaviorists that you may have heard about in your intro psych classes, and Dr. Hoffman has already referred to us and set us up for some of these. You might remember Watson and his experiments in terms of conditioning a phobia in poor little Albert, so that he paired a very loud noise with a fluffy rabbit, and that fear then generalized to bunnies and all kinds of other things. And you may remember Skinner and how he used rats and pigeons to identify that the strength of a behavior is modified by its consequences. However, in the 1950s, we had this cognitive revolution that Dr. Hoffman referred to earlier. There was a shift away from strict behaviorism. Researchers began to examine the link between unhelpful cognitions and problem behaviors. They began to view emotional and behavioral problems as resulting less from events in the environment and more the result of an individual's appraisal of the events. In other words, thoughts matter. Aaron Beck's cognitive therapy and Albert Ellis's rational emotive behavior therapy really sought to help people evaluate their thinking patterns using strategies like guided discovery and direct refutation. And these treatments gained widespread popularity due to research showing their efficacy for a range of psychological disorders. So what's the third wave? The third wave really refers to a collection or family of therapies that emphasize mindfulness of internal experiences and acceptance instead of change. So there's other themes that have been associated with third wave behavior therapies, although less consistently. Ideas like metacognition, cognitive fusion, values, dialectics, an increased emphasis on the therapeutic relationship, and a greater emphasis on behaviorism, so that first wave. So the therapies most commonly associated with the third wave include ACT, DBT, and various mindfulness-based approaches. Thanks. Okay. A number of other cognitive behavioral based therapies have also been associated with the third wave, but less consistently so. And so these are some of the therapy developers that you may associate with third wave. So Stephen Hayes, Marsha Linehan, and people like John Kabat-Zinn or Zindel-Siegel for the mindfulness-based approaches. But what's distinctive about third wave CBTs? What differentiates them from so-called second wave or traditional CBTs? So some of the more common features are the use of mindfulness as a core practice, and you're going to hear more about that today, an emphasis on accepting the present moment, and a return to first wave behavioral principles. Perhaps most notably, however, is how third wave therapists tend to respond to thoughts compared to their second wave counterparts. While second wave CBT has tended to focus on the content of a person's thoughts, identifying, challenging, modifying a person's thoughts, assumptions, and core beliefs, third wave therapists have focused on the individual's relationship with their thoughts, targeting the function of the thoughts rather than their content. So while the second wave cognitive therapists might focus on helping a client evaluate the accuracy of their thinking in service of changing the thought, in third wave approaches, the therapist would look at the person's relationship with their cognitive events. ACT doesn't debate whether a thought is true or false. It focuses on whether a thought is workable. Does it help the client move toward living in accordance with their values? DBT focuses on whether holding the thought is effective. Does it help the client to do what is skillful, what works? So the traditional cognitive therapist might say, well, let's look at the evidence supporting or disconfirming this thought. The ACT therapist might say, if you let this thought guide your behavior, will that help you create a richer, fuller, or more meaningful life? The DBT therapist might say, let's not judge these thoughts as good or bad. Does holding on to these thoughts help you to be more effective? So proponents of third wave therapies argue that it's not the content that is the problem, it's fusion with the thought. How caught up or absorbed by the thought the person gets. The goal is to change the relationship with their thoughts, not as a means to control how they feel, but as a means to become present and take effective action. The idea that there is a third wave of CBT is not without controversy. So many well-regarded researchers and clinicians have argued that the third wave is not really new, that good cognitive behavioral therapy includes examining the function as well as the accuracy of cognitive events. And indeed, Dr. Hoffman has written very eloquently on the subject. However, it's hard to know what is standard or traditional CBT and what is new. Certainly, standard CBT looks very different than it did 20 years ago. And so I'd like to leave you with Marsha Linehan's assessment. Whether the differences between DBT and standard CBT approaches are fundamentally important is, of course, an empirical question. In any event, CBT interventions have expanded their scope since DBT first appeared, and components of DBT have made their way into standard interventions. the differences between them and DBT have eroded. And of course, you can substitute ACT for DBT in this. To conclude, regardless of what we call the series of interventions we're presenting today, they've certainly changed the face of cognitive behavior therapy, and we hope you find them as compelling as we do.
Hello, it's me again. So now you're all excited, right? Because there might be more activities you have to do. So I'm going to be presenting on acceptance and commitment therapy, and I will indeed be asking you to do some of the exercises. And this is part of the philosophy of ACT, in that ACT is thought to be transdiagnostic, and so it's good for everybody. It's good for understanding ourselves as therapists. It's good for understanding why your mother does that thing she does, and it's good for understanding patients. And so it's actually part of the philosophy to use some of the techniques on yourself. So you'll know that you're at an ACT workshop when you have to start doing exercises. And so welcome for the next 10 minutes or so. So, this is some of the main principles of ACT. There is different things that ACT therapists focus on. And the main goal is psychological flexibility. And that's the ability to adapt, to respond flexibly to the demands of the situation. In order to do that, ACT therapists focus on being present, opening up, and doing what matters. So that's just a quick overview of the model. Okay, ACT has been empirically validated. So it's been shown to be effective for chronic pain, depression, mixed anxiety, obsessive-compulsive disorder, and psychosis. As I said, it's also viewed as being transdiagnostic. So there are also a number of RCTs looking at the effectiveness for a whole range of different disorders. So one of the main ideas from ACT is this idea of passengers on the bus. So this is one of the classic metaphors in ACT. And so what I want you to imagine is that you are a bus driver. And on your bus, there are all kinds of passengers. And some of them are friendly and welcoming, but some of them are kind of rude and annoying. And so for all of us, we have these passengers on our bus. And those are like the thoughts and the feelings and the sensations that we all have. And so when we try to take our bus somewhere that we want to go in life, sometimes the passengers might have their own opinions about where we should go. So for example, if you take somebody who has social anxiety and they want to go to a party, well, they have a passenger on their bus, Mr. Anxiety, and he starts yelling and screaming and saying, oh my gosh, this is terrible. You don't know anybody there. This is going to be awful. You're going to feel terrible. What are you going to do? And you might start feeling anxious and noticing. And so all of a sudden, the gentleman who wants to go to the party goes, oh no, this is not good. I don't want to feel this way. I better take a detour. I better get off this route and go somewhere else. And so part of this metaphor helps us understand and helps patients understand how to have a different relationship with their thoughts and feelings. And so there's two sort of skills that you need in order to take the bus where you want it to go. First, you need to know where you're going. So if you've ever kind of had a kid trying to get them to fall asleep and you put them in the car and you drive around aimlessly hoping that they'll fall asleep. So if you don't really know where you're going, it's quite easy to have the passengers take you astray and take you somewhere where you didn't mean to go. So one of the key skills is to know where you're going. The other one is to actually be in charge of the driving and to not let the passenger sort of overtake the bus and take it places you didn't mean for it to go. So we also sort of have to have a different relationship with our thoughts and our feelings in order to take the bus where we want it to go. And so I always give the example of a real HRM bus driver. If they were driving the bus and one of the passengers was on the bus and said, my house is just over there, so I was wondering if you could take a left and just drop me off in front of my house. Would that be okay with you? What do we think a real HRM bus driver would do or say? He'd probably say, no, I'm sorry, I can't drop you off in front of your house. I have a route to follow. And that's sort of the attitude we want patients to come to with their thoughts and their feelings, is that they can acknowledge their thoughts and feelings, recognize that they're there, but take the bus where they want to go. So part of this is we clarify for patients what their values are, and that helps them know where their route is, where they're going to go. So values are like directions. So values represent the kind of person you want to be, what's really important to you, what you want to stand for in life, and it's a little bit like a direction. So if, for example, if it's important to me to head north, then there will be some markers along the way that will tell me that I'm heading north. So if I'm heading north from here, then, eventually I'll hit the 102 highway. And if I keep going, then I'll hit Truro. And if I keep going, I think I hit Newfoundland maybe. So, but those markers would tell me I'm heading north, and they tell me I'm going in the right direction. But if it's important for me to head north, every step I take north also counts. And so values are like directions. You also never get north. You're never done heading north. You never get there. And so if it's really important for me to be a kind and loving person, there may be markers along the way that tell me I'm on the right track. Maybe I get married and that says, oh, I must be kind and loving because I found a partner. But there's also a ton of little steps along the way, so I can go home and kiss my kid, and that would also be me being a kind and loving person. I also never get to stop, so I can't say, you know what, in 1984 I was super nice to my sister, so I'm a totally kind and loving person. Right? I have to keep expressing that value on a day-to-day basis to be showing that that's important to me. So one of the things that we do for patients in ACT is to help clarify what their values are, what's important to them, so they know where they're trying to head. Okay, then we need to turn those values into behavior. And so this is also where the behavior therapy comes in. And we want to focus on behaviors. We talk about behaviors as something that somebody else can see you do. So people get quite caught up in wanting to feel a certain way and wanting to think a certain way, and we have a lot more control over our behavior. So we try to identify the smallest possible step people can take in terms of heading north or in terms of heading in a direction that's meaningful and important to them. Okay, so I say it's like the reality show of your life. So if you had a reality show, behavior are the things that we can see you do. Okay, so what I could see, so it's not the voiceover part, it's not, where they do the little commentary. The things I can see you do is a behavior. And this is to help clarify for patients, what are they trying to aim for? What are they trying to do differently? Is their behavior. Okay, then our second skill is that we need to try and drive the bus in a different way. We don't want the passengers to keep hijacking the bus and taking the bus in places we didn't mean to go. So in this, we use mindfulness as a tool to help notice and unhook from unhelpful thoughts, feelings, and sensations. So our goal there is similar in mindfulness traditions, is to be able to notice our thoughts, but not get caught up in them, to just allow them to be and allow them to move on. And so we use that as a tool. And so in addition to sort of formal mindfulness activities, you can also do mini mindfulness activities like present moment awareness. So just trying to be present in this moment. So I'm sure many of you have busy minds, which are working the way they're supposed to be working, and maybe thinking about other things than my talk. I'm shocked, I know, but I'm sure it happens. So present moment awareness is to try to come back to this moment. And we do that by noticing our 5 senses or noticing our breath. So our thoughts are often in the past or in the future, but our 5 senses are right here in this moment. So whenever you can connect back to your 5 senses, you've come back to this moment. So for example, noticing the brown podium, noticing the gold carpet. When I notice my 5 senses, the things I can see, the things I can hear, then I've come back to this moment. And then my mind takes me away again, and that's what minds do, and that's totally normal and okay. And then we practice bringing our mind back. So it's a skill that helps people know what their minds are telling them and to disconnect from them enough that they can take the bus where they want to go. Okay, so another sort of skill in that is becoming an observer. So often our patients feel like they're in an emotional storm, right? There's lots of feelings and thoughts, and it's like being in a hurricane. There's all this torment going on. And our goal is to give them this kind of perspective instead. So to be able to pull back and to notice and to observe their behaviors and their thoughts rather than being all caught up in them. So this perspective, the satellite perspective, is a much different experience of a hurricane than when you're in it. So, you know, when you see the reporters and they're like in their rain gear and they're being thrashed around, right? That's much different than when you get to see the satellite picture. And so the goal is to help patients be able to pull back enough that they can notice their thoughts and their feelings. And if you can notice your thoughts and your feelings, then you're not your thoughts and your feelings. So to give them enough space between their thoughts and their feelings so they don't get all caught up in it and take the bus where they don't mean to go. And so it's a little bit like the idea that we are the sky and our thoughts and the feelings are the weather. So the weather comes and goes, but the most violent tornado, the worst hailstorm, it never damages the sky. And the sky is always big enough to handle the weather. And so even though sometimes you can't see the blue sky, it's still there. So we are the blue sky, and our thoughts and our feelings are the weather that come and go. And so we're trying to teach patients that perspective so they can be in charge of where their bus goes. Okay, so diffusion is another technique that we use in ACT to help patients get some space between their thoughts and feelings. So what I'd like you to do, it's another exercise, yay! I want you to take your two hands. So imagine that your life is everything that's out in front of you. And I want you to take your two hands and put them right smack up against your face. Okay, now how hard or easy would it be to live your life with your hands like this? I can't really tell what you're doing because I can't see you guys. Okay. Easy, hard, what do we think? How hard? Okay, now I want you to push your hands out in front of you as hard as you can. Get them as far away as possible. Okay, how would it be to live your life this way? Maybe a bit easier, but I don't know about you. My arms are getting a bit tired. Okay, now I'd like you to put your hands in your lap. Okay, how would it be to live your life this way? Better. Okay. So our hands are like our thoughts and our feelings, right? Sometimes we get all caught up in them, we're all worked up in them, and we can't sort of live our life. Sometimes we try really hard to get rid of them. Drugs, alcohol, all kinds of other things to try and get rid of our thoughts. The way we're working on an ACT is to have your hands in your lap, which means they haven't gone anywhere. You still have hands, you still have thoughts, you still have feelings, but they're not interfering as much in how you want to live your life. Does that make sense? Okay, so this is my little anxiety puppy. And what I'd like you to imagine is, imagine that you have to go do something that makes you a bit anxious. And imagine those feelings of anxiety that show up. And I can ask you to do this because I know as a human being, you've felt anxious before in your life. There's nothing unusual about feeling anxious. It's a normal human experience. And so if you can imagine feeling anxious because you had to do something, and then I want you to imagine that all those anxiety symptoms, so that, you know, your heart racing or feeling tense in your stomach or your mind sort of racing, imagine that all of those kind of anxiety symptoms are this little puppy. He's your little anxiety dog. And he's there because he's trying to protect you, right? He thinks there's something bad in whatever you're about to go do, whether it's giving a talk or having to go to a party. And so he's trying to protect you. And so he starts yapping, right? Yep, 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 yep. And when you talk to patients who have anxiety, they really relate to this. They can really experience that little dog yapping at them. Okay? Now, sometimes when you have a little yappy dog and somebody comes to the door and they ring the doorbell and the dog goes, yep, 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 right? Goes a little crazy. Now, sometimes it's just the mailman, right? And he really doesn't have to go all yappy. It's not something dangerous. It's not something to be scared of. It's just the mailman. And so what would we do with that little puppy? The little puppy is going a little crazy because there's a knock at the door. What kinds of things might we do with that puppy? Pardon? Remove him. Yeah, we could go get him away from the door and probably bring him back to us a little bit. What other kinds of things might we try to kind of calm the dog down and kind of remind him it's okay? Right. And that's sort of the attitude we want people to take with their feelings, is to treat their feelings like that little yappy puppy who just kind of doesn't know any better and he's yapping at everything. And we would want to treat that little anxiety puppy with some care and some concern and some self-compassion, and just try to be calm with the puppy and remind him it's okay. But hopefully nobody's going to kick the dog across the room or, stuff him down somewhere, right? Which is what people do try to do with their anxiety, right? They try to make it go away. And our job is to help them make space for that anxiety in a way that's kind and compassionate, because it's a normal human experience, so that then they can go do whatever it is they want to do. Does that make sense? Okay, so part of my job at Capital Health and Nova Scotia Health Authority, I used to say the artist formerly known as Capital Health, but now because Prince is gone, it has this whole other connotation. So part of my job there is working for the Behavior Change Institute, and we provide training for healthcare providers in behavior change counseling skills. So we have modules on emotion management that are based on ACT. It's free to all Nova Scotia Health Authority employees. So there's more training is available. If you want more information about the Behavior Change Institute, we have a website. Additional resources, if you're looking for more on ACT, we have a peer support ACT group that runs the third Friday of the month from 4 to 5:30. It's at the Mumford Professional Center where primary care is located. We have offices upstairs, meeting room upstairs that we use. There's also contextualscience.org is the association for ACT. And we also have an Atlantic chapter that we recently opened in ACT as well. So you can also become a member of both organizations and come and learn from us. And that's my email at the bottom. These are some book resources if you're interested. So ACT Made Simple is for therapists or healthcare providers. The Happiness Trap and the Reality Slap are for the public, but they're also great reading just for individuals if you want to know more about ACT. And it'll be on some website somewhere that you can go back to these slides if you want to get more information. Okay, thank you.
So I'm going to talk about DBT, and we borrow a lot of exercises from ACT, but this is not going to include quite as many exercises this time, so that is not permission to fall asleep. To provide some background, DBT was developed by Marsha Linehan in the 1980s. It was developed for chronically suicidal individuals and then adapted for people with borderline personality disorder. It's important to note that Linehan did not develop it as a suicide prevention program. She sees it as a life enhancement program. So she recognizes that many individuals with BPD don't feel that their lives, as they currently are worth living. And the overarching goal of treatment is to help them develop a life worth living. DBT is a therapy that we refer to as technically eclectic but theoretically consistent. So the theories are behavior theory and science, Zen Buddhism, and dialectical philosophy. These form the basis. But a DBT therapist will commonly incorporate interventions from other traditions. So, for example, an empty chair technique from Gestalt therapy or something like that. DBT has a strong evidence base, and it is indeed the BPD specific program with the most empirical support behind it. But how does DBT differ from traditional CBT? And that's what I want to focus on today. And I'm going to talk about six different ways in which it does, Linehan added to traditional CBT with DBT. So first of all, I want to talk about the synthesis of acceptance and change, the emphasis on dialectics, the emphasis on the therapeutic relationship and treating, specifically targeting therapy interfering behavior, the treatment team, which is very integral to therapy, the emphasis on stages of treatment and targeting behaviors according to severity and threat, and mindfulness as a core skill. So with regard to the first one, the whole idea of synthesizing acceptance and change really came out of Marsha Linehan's early work treating chronically suicidal clients. So she was trained in standard CBT, and she was really keen to teach suicidal clients the problem-solving strategies that she knew would help alleviate their suffering. But how does one treat these multiple problems? So your typical client with BPD is going to have mood problems, is going to have several anxiety problems, eating difficulties, substance use problems. And how do you treat all that when they're constantly in a state of perpetual crisis? So treatment with such clients is very complicated. When we focus on change, the client panics because such efforts have often failed in the past. Further, the focus on change often triggers shame or anger at the implication that change is possible. So you, the therapist, don't have a clue how impossible change really is. Or you believe, like others have in the past, that the problem is I'm just not motivated enough, or there's something wrong with my personality. If instead the therapist drops the change orientation and focuses on accepting the client's limitations and vulnerability, this also invalidates the client. It invalidates her misery. It sets off despair that things will never change. Either way, expecting change beyond the client's ability or accepting the client's limitations is experienced as invalidating, leading the client and the therapist to feel desperate and overwhelmed. They're not able to process new information, and the result is no new learning, not to mention a poor therapeutic relationship. So Linehan's solution was to apply a dialectical approach. That is to both validate the uncontrollable, helpless experience of intense emotional pain and to teach emotion regulation. So in response to intense reactions during a therapeutic task, the therapist needs to both validate the pain and teach the individual to modulate in the session. So this is done moment to moment, balancing the use of supportive and validating acceptance strategies and more confrontative change strategies. So in essence, the therapist is teaching two new sets of behavior, acceptance skills and change skills. And the strategies for teaching these are validation and problem solving. Or, put another way, DDBT represents a balance between behavioral approaches, which can be thought of, so the CBT approaches, which can be thought of as technologies of change, and the humanistic and client-centered approaches, which can be thought of as technologies of acceptance. So while standard CBT provided a number of well-validated change skills, it was less clear for Linehan in terms of how to provide the validation. So taking from validation therapy and other humanistic traditions, she came up with 6 levels of validation. While other models routinely use the first 3 or 4 of these, what DBT really emphasizes is 4 and especially 5 and 6. DBT emphasizes the importance of validating in terms of the current context, identifying the client's emotional response as a normal reaction to the situation. The emotional response is normal, the client is just overshooting the mark. Level 6 validation is called radical genuineness, and it refers to the therapist conveying his or her genuine response to the client. The therapist doesn't treat the client as fragile, but rather like a robust individual who can hear the truth. DBT invites therapists to respond to their clients as they would to a family member or close friend who reported the same events or emotional responses. So CBT represents the change side of our dialectic, and it includes a number of traditional cognitive behavior strategies. So for example, the therapist will use behavioral analysis to target problem behaviors such as suicidality, therapy-interfering behaviors, or substance abuse. So that's that dark circle. And chain analysis involves assessing in moment-by-moment detail everything the client thought, did, experienced, felt, from the events that made the client vulnerable to the behavior to the consequences of the behavior. So we're coming right back to antecedents and consequences in terms of determining what's going on with the client's behavior. And the behavior chain analysis provides the foundation for a thorough solution analysis, which is then used to identify what things in the environment do we need to help the client to change, what skills does the client need to use, what upsetting emotions does the client need exposure therapy for, and what beliefs need to be challenged so as to take down the client down another route and avoid the problem behavior occurring again. And just to note, your typical behavior chain analysis would typically have 4 to 5 times that many links. Contingency management is another a very important part of DBT. And this comes, again, right out of that first wave of CBT. So you remember Skinner and his pigeons. And when they were rewarded for pecking at the disc, the frequency of the pecking increased. So contingency management, fancy term that really just refers to the fact that the consequences of a behavior affect the probability of that behavior happening again. So our clients often have a history of being reinforced for maladaptive behaviors, thus increasing these behaviors. So in the past, if they've often experienced that their inner experiences were dismissed, were ignored, were in other ways invalidated, and then suddenly they attempted suicide and they got all these expressions of care and affection and support, well, that's really validating of the suicide attempt. And we, the caring and compassionate clinicians that we are, we're very inclined to try and alleviate our clients' immediate suffering. When our client acts helpless, our first instinct is often to try and rescue them. When they escalate their demands on us, we think they must really need our support, and we acquiesce. Yet we need to consider that every response is a potential form of reinforcement, punishment, or extinction. As much as possible, we want to reinforce and shape skillful behaviors, those that we want, for example, using our relationship with the client, our attention or our approval as reinforcement. We can also extinguish unskillful behaviors by eliminating reinforcing responses, and as a last resort, provide aversive consequences for unskillful behaviors. Skills training is a major component of DBT and includes skills training in mindfulness, interpersonal skills, emotion regulation. But to come back to the main, to come back to my main point, DBT can really be summarized in terms of the change acceptance dialectic. The therapist creates a context of validation and acceptance, and within that context, blocks or extinguishes the problem behaviors, drags the skillful behaviors out of the client, and figures out a way to make the skillful behaviors so reinforcing that the client continues with the skillful behaviors and stops the problem behaviors. So, quite a task. How does the therapist do it? They adopt a dialectical stance and use dialectical strategies. Taking a dialectical perspective means understanding that suicidal clients often simultaneously want to live and want to die. Saying I want to die aloud to one's therapist rather than killing oneself in private contains within it the opposite position, the position of I want to live. This doesn't mean that wanting to live is more true than wanting to die, and it's important that we remember that. So many clients with BPD genuinely do not want to live their lives as they currently are. The client sees suicide as the only option. Rather than become polarized in a dialectical approach, the therapist agrees that the client's life is unbearable and that they need a way out, and offers another route, using therapy to build a life that's genuinely worth living. I had one of those month-long colds that has decided that it's just going to rear its head now, a couple weeks later after it's gone. Another way of thinking about dialectics is to think of it as the middle path between the idea that truth is absolute and that truth is relative, okay, that it depends on perspective. So dialectical thinking holds that truth evolves and develops over time. In disagreements, truth is sought through efforts to discover what's left out of both people, the ways both people are viewing events. So truth transcends polarities. It's created by including what was previously excluded. A dialectical perspective holds that one can't make sense of the parts without considering the whole. So clinicians never have the whole perspective on a client. Rather, therapists are like the story of the blind wise men, each touching a part of the elephant, and each being certain that the whole is exactly like the part that they're touching. So one is touching the ear, an elephant is big and floppy. Another is touching the trunk. No, an elephant is long, round, and thin. Somebody else is touching the leg. No, an elephant is solid like a wall. Each perspective is true, but each is also partial. So in DBT, we are constantly balancing acceptance and change, validation and problem solving, structuring the environment with encouraging the client to change their response to the environment. And finally, we're balancing our communication style, reciprocal and irreverent communication. So reciprocal communication, we're emphasizing acceptance and warmth, directly responding to the client without interpreting any latent meaning. Irreverence refers to reframing a client's communication in an offbeat or unorthodox manner, plunging in where angels fear to tread. So given that you assaulted your last therapist, let's start with what led up to that and how that's not going to happen to me, because I'm not going to do you any good if I'm afraid of you. The importance of establishing early on a strong positive therapeutic relationship cannot be overstated. Often the therapeutic relationship is the only reinforcer for a person with BPD to change their behavior. Yet as soon as that relationship is established, the therapist begins to communicate that the rules have changed. Whereas a client may have previously believed that if she got better, she'd lose the therapist, she's now told that if she doesn't improve, she'll lose the therapist much more quickly, because continuing ineffective therapy is unethical. The therapist is putting the quality of the relationship on the line for improved behavior. So the therapist is really balancing in terms of, as well as acceptance and change, both nurturing the client, coaxing them along, with benevolent demanding that the client pull out those behaviors that they're capable of. So essentially reinforcing adaptive behavior and refusing to take care of the client when she can take care of herself. They're also balancing unwavering centeredness, so calmness amidst chaos, with compassionate flexibility. So taking in relevant information and modifying your position. So the odds of making a mistake in DBT, very high. And having an overall willingness to admit and repair mistakes, such as smiling at the wrong moment, getting into a power struggle with a client. And this is an essential component that needs to be balanced. The treatment team is a unique and central part of therapy. A key assumption of DBT is that therapists treating people with BPD need support. The consultation team very much functions to help keep the individual therapist in the therapeutic relationship. So it cheerleads and supports them. It also functions to balance the therapist in their interactions with the client. So it might remind the individual therapist that while the individual therapist is getting very frustrated because progress in individual therapy gets very slow, perhaps the skills training therapist can say, well, you know what, I'm actually seeing them be a lot more skillful in group. So it really helps them provide that balance and helps them stay in touch with their empathy for their client. DBT also uses, one of the more unique characteristics is this idea of using stage therapy to structure treatment and identify which behaviors to target. And pre-treatment, getting a client's commitment to treatment is considered especially important, because DBT is not it's a voluntary treatment. It's for people who are saying that they want to work on their suicidal behaviors, on their parasuicidal behaviors as well. So the idea is that there's a willingness to work on that. It doesn't mean that it's expected to be just gone, but it means that there's a willingness to work on decreasing that. And following pre-treatment and really getting the client's commitment to work on this, then you're really working on what we call stage 1 targets. And that's really reducing behavioral discontrol and helping the client get into more behavioral control. So we often refer to what we call as a house of treatment, that we need the foundation, we need the stage 1 skills in place. The client needs to be able to manage their emotions before we would consider going to stage 2 work, which would be the emotional experiencing, the PTSD work. So we're not going to delve into exposure for prolonged exposure for PTSD if we've got a client who is dissociating all the time. And where DBT really places most of its emphasis is especially stage 1 and stage 2. And coming back to stage 1 is really also broken up in terms of, we think about imminently life-threatening behavior and that we want to target that first. You need to be alive to be able to come to therapy. Then we want to target therapy-interfering behavior. You need to be getting to therapy to be working on these problems, and then targeting quality of life behavior. So this really determines what we're going to focus on in treatment. In DBT, mindfulness is considered a core skill. Dr. Whitehorn is going to be speaking about mindfulness, but briefly, I just want to talk about this idea of states of mind. So, wise mind is something that we're aiming for with clients, to get in touch with their wise mind. And wise mind is characterized, excuse me, by an integration of emotion mind. So this is the hot, impulsive, just reacting to emotions, and balancing that with a more intellectual, reasonable mind, which is more sort of cool and calculating in a good way. The experience of wise mind is it combines a sense of intellectual knowledge, but also intuitive wisdom. So it's both taking the reason part, but honoring the emotional experience. And the practice of the other mindfulness skills are to facilitate access to wise mind. And with that, I'm just going to put up a few resources before I turn it over to Dr. Whitehorn. So there's really no substitute for Linehan's text and skills training manual for doing DBT. These are a couple of resources that are very helpful for clinicians doing DBT. Behavioural.org and practiceground.org, which is developed by Kelly Kerner, who is a just amazing clinician and a very important researcher as well. And a couple of excellent self-help books. And I really can't recommend, especially the first one, enough for clients who might be sitting on a wait list for a program or just not have access to resources. That this often is a really good starting point that is both very validating, but also talks about what change looks like. Thank you.
Good morning. How's everybody doing? Good. So my piece of this is to round out the therapies that are so-called third wave and are have the name mindfulness based in front of them. As you can see, all of the third wave therapies we're talking about are mindfulness based, in the sense that mindfulness is a core component of all of them. So the ones that have mindfulness based as in their name, the original one is mindfulness based stress reduction, MBSR, which was developed in the late 1970s by John Kabat-Zinn. Interestingly, Kabat-Zinn was not a clinician. He had a PhD in molecular biology, and he got into this because he got very interested in Zen Buddhism and was studying that. And at some point on a retreat, silent retreat, it suddenly occurred to him that this mindfulness stuff they were doing would be very helpful for people in general and did not have to be put in the context of some spiritual path at all. An idea which still remains slightly controversial in the spiritual world. But nonetheless, he did that and developed MBSR, which is an 8-week program, a multi-component program. There is mindfulness meditation in it, but there are many, many other pieces to it, movement pieces and things that we would certainly identify as cognitive based. The second major mindfulness-based therapy is mindfulness-based cognitive therapy. This was developed in the 90s by Zindel Siegel at the University of Toronto. So in Canada, we have a claim to MBCT, but with two British clinicians, John Teasdale and Mark Williams. And there's an apocryphal story about this that Zindel Siegel and all of them were cognitive therapists. They were trained cognitive therapists. That they went to John Kabat-Zinn with the idea of, why don't we kind of take your mindfulness-based stress reduction and we'll actually put it together with some real cognitive therapy that we know how to do. And how about you help us with that? And he said, no. And they said, how come? And he said, well, among the three of you, only one of you actually does mindfulness practice yourself. That was John Teasdale. And supposedly the story is that Siegel and Williams went away and started meditating, came back to Kabat-Zinn and said, okay. But the point was, and Kabat-Zinn still holds this point, that to teach mindfulness, you have to do mindfulness. You have to embody it, which means you have to practice it yourself in some form. It's not something that you can do unless you have the actual personal experience of it. So MBCT, Dr. Hoffman put some of the evidence up. This is a very strongly, MBSR has been studied. There's thousands of studies of MBSR, and MBCT has been very well studied, and probably the strongest evidence is in this relationship to treatment of depression, and particularly for prevention of relapse in depression, and particularly there for people who have had several episodes of depression already. Interestingly, it doesn't work very well for people who have only had one episode or two, and it is not recommended during an acute episode. MBSR is, again, an 8-week program, multiple components to it. And then more recently, there's a MBRP, mindfulness-based relapse prevention, is developed in Seattle by a group there. And there's I think some good evidence there that that's helpful in terms of addictions. So relapse in terms of addictions. And there are probably many, many other programs around. Lots of people have programs that have mindfulness-based in their name somewhere or another. One of the things I wanted to just stress with this is that these programs all are multi-component programs. There's mindfulness in them, but there's many other things. And a lot of the research recently has been trying to tease out to what extent is the mindfulness component essential, and what does that do, and so forth. So then you now beginning to have studies with active controls where you pretty much do the same therapy but leave out the mindfulness and so forth. So that as you're looking at the literature, that's important to look at whether there were active controls in the studies. So I'm not going to talk about the details of these therapies for several reasons. The main one is that I'm not trained in these therapies. I'm not a therapist that's in these. So to deliver these programs, you need to go through a proper training program, and we're beginning in Nova Scotia to have some opportunities for people to get properly trained in this. So what I'm going to do instead is talk about mindfulness itself, which, as we've said again and again, is kind of the foundation, a core foundation of all the third wave things. And I'm going to go back to John Kabat-Zinn. It's an interesting field in that there's one person who's still alive who started the whole field, and you can go back and reference him. He's kind of the conscience of the mindfulness movement, so to speak. And recently, Kabat-Zinn offered an interesting description of mindfulness. And this is in a report that came out of a parliamentary committee in the UK, where they have endorsed and recommended the use of mindfulness-based interventions in a number of different sectors. And as you can see in this, Kabat-Zinn is suggesting that mindfulness itself, and the way he's using this word, is basically, we're talking about awareness, and he calls it pure awareness. And this might be differentiated from other forms of awareness, which particularly thinking, and goes on to say it's an innate human capacity. So I'd like to emphasize that innate part. This is a very important concept, I think, that mindfulness is innate. We already have it. All people have it. It's just part of the equipment that comes as a human being. So when you do mindfulness practices, you are essentially cultivating or allowing an innate capability to come forth. You are not actually learning a new skill. In fact, a lot of people would say that mindfulness has a lot to do with unlearning. But in any case, innate capacity that is different from thinking, but wholly complementary to it. So it is a different way of experiencing. And he calls it bigger than thinking, because any thought, no matter how momentous or profound, illuminating or destructive, can be held in that kind of awareness and thus looked at, known, understood in a multiplicity of ways which may provide new degrees of insight and fresh perspectives for dealing with old problems and emergent challenges, whether individually, socially, or globally. So he's really, my sense is this is a very, very core competency for a human being, to be able to rest in your innate, natural, pure awareness or mindfulness. And therefore, it's something that can help you do almost anything in life. Certainly, we've seen in the therapies that have been developed around it, it's extremely helpful in supporting the therapies. A more well-known definition of mindfulness from Kabat-Zinn again is what he calls an operational definition, and we've seen a bit of this already. Mindfulness means paying attention in a particular way on purpose in the present moment and non-judgmentally. So that's sort of what you do operationally in order to try to cultivate or allow your innate mindfulness to occur. You pay attention in a particular way in the present moment and non-judgmentally. And that word non-judgmentally, that phrase, is a very interesting one to consider. What in the heck does that mean? Does it mean that you're stupid and you don't know anything? Does it mean you're blank? And the answer to those questions is no, it's not that. Well, what is it? What does it mean to be non-judgmental when you have an experience? One way that people have talked about it is that you just let the experience be what it is and you don't add or subtract anything from it. Don't embellish it. Don't put any extra layers on it. You simply experience it as it is. But I think that non-judgmental part is always an open question, and a good open question. What does that actually mean experientially? So mindfulness practices are ways of creating conditions in which we can pay attention in the present moment non-judgmentally, in which we can allow that innate mindfulness to occur. And there are just a multitude of practices, if you want to put it that way, activities that you can do that will cultivate mindfulness. Meditation is one, but it's certainly not the only one. We've already heard you can use almost any situation as a trigger or a stimulus for being present in the present moment, non-judgmentally. The really basic mindfulness practice, as we already heard, often is based on coming to your senses. This is a term actually that Kabat-Zinn has used time. Come to your senses. It's interesting because it's kind of an old saying. Somebody's kind of bouncing around and you say, wait a minute, just come to your senses. Well, it's interesting. When you come to your senses, you come back to the present moment. For a variety of reasons, it's often recommended that you use your body sensations. They're a little bit less complicated than the visual or auditory in terms of embellishments. And those sensations are occurring in the present moment always. The movements associated with breathing are one that's commonly used, but you can use any one. And the interesting thing, we were talking already about present moment mindfulness. You can become mindful in an instant, anytime. So right now, let's just become mindful. Just bring your attention to the sensations coming from your body. You might feel your feet on the floor, your bum on the chair. You might notice your breathing. That's it. No big deal. Everybody can do that. And frankly, that particular kind of exercise, present moment exercise, where you just right on the spot, just come to the present moment, I think is one of the most powerful and useful because you can do it anywhere. You're in the middle of a lousy meeting where everybody's droning on about the same stuff again and again. Just come to the present moment. What else are you going to do? Your wife is reminding you for the umpteenth time that you're not paying attention to what she's saying. Experience I have frequently. Come to the present moment. Yeah. So very easy, very handy, and very effective, actually, in cutting through whatever kind of conceptual storyline you're on. So the other piece that we wanted to add to this was something about compassion. And this came up in Dr. Hoffman's talk quite a bit, that John Kabat-Zinn actually has at times used the word heartfulness as a replacement for mindfulness, because he was getting concerned that mindfulness seems very cerebral. It's kind of, something where you're paying attention a lot, and you're not embellishing your thoughts and everything. It sounds, but the actual experience of it feels more like maybe it's coming down here. It has a warmth to it. It has a compassionate, caring sense to it. So this form of awareness, this pure awareness, is inherently compassionate. There's an inherent sense of interest and curiosity about what's happening with people. So sometimes he's called that heartfulness. That term hasn't actually caught on, but it's an interesting one to keep in mind. And so many of the mindfulness-based therapies, as we've heard, actually have formal practices that are related to cultivating compassion for self and others. And if you haven't looked at Paul Gilbert's work, I think it's really interesting work. He's in the UK, compassion-focused therapy, where the whole therapeutic process is based around the construct of compassion. And we were talking, Dr. Hoffman brought up the self-compassion. I particularly reference Kristen Neff, who's done a lot of, we're not the only person, but she has very nice practice. She has a good website, I think it's just called Self-Compassion. And it has some nice exercises. Somebody was asking about self-compassion exercises there. And also, loving kindness practice was mentioned. This is was part of MBSR, and it's part of MBCT and all of those. So I thought we thought we should just end this by just doing mindful loving kindness practice. Again, I'm not a therapist, so I'm not going to do this in the way. If you were a therapist, you would have a script, structured script, which would lead people through. There are many forms of this. This is borrowed directly from Buddhism. And basic idea, I think there's two components to this. So let's just actually do this. Usually for any of these be a contemplative practice. The way to start is with mindfulness. So bring your attention to the present moment, just by using your body. And then one way to do loving kindness is bring to mind somebody or a situation in which you have experienced loving kindness. A person, situation, some people use a pet. So that you can bring back your previous experiences of just unconditional love and concern. Maybe it's someone who's had that towards you. So that's one piece of it, one way to do it. That's something you can also do in the moment. No one knows you're doing it. You can do it secretly. And then the next piece of it usually is some sort of aspiration, where we begin to develop a narrative or talk to ourselves. And that's in the form of, may a person that I'm concerned about be happy. May this person enjoy their life. You can actually make up your own script of these. They're always in the form of that. May this person appreciate their life. And then you can turn those aspirations toward yourself. May I be happy. May I appreciate my life. May I be able to use my life in a way that I feel is worthwhile. So again, very simple practices. I think a lot of people suggest that, again, if you create those aspirations yourself, then they have particular meaning to you, and so forth. So I'll stop there. There are some online resources. Pretty much you just Google MBSR, MBCT, and you get these. Again, compassion-focused therapy. And there is a, mindful.org is an interesting thing if you want to see how mindfulness is being used throughout the world. And there are a number of references. I think Dr. Hoffman was mentioning this one in JAMA Psychiatry. A number of good meta-analyses these days. So I'll stop there. Thanks.
Thank you very much to all of you. So we now have time for questions if you just want to line up behind the microphones.
Thank you for the presentation. I have a question directed towards Jackie Cohen. You said that, I think it was this, I don't know if it was the second or third stage of DBT, was to do the exposure therapy. And I do some cognitive behavioral therapy, and what I've learned about exposure therapy is that when traumas are associated with feelings of fear, that exposure can work really well. However, some traumas are also associated with feelings of shame. And I can't help but imagine that people with borderline personality disorder would have those types of traumas and have those types of feelings. So I'm wondering if you could speak about the exposure therapy with people who have overwhelming feelings of shame.
And this has been it's been such an interesting area in PTSD work. So a person to really look at their stuff is Melanie Harned, Harned. So Melanie Harned has essentially trained with both FOA and with NFO, who developed a prolonged exposure, and also Marshall Linehan. And what she has done is essentially taken the really been able to package how to put DBT and PTSD and prolonged exposure treatment together. And what she's doing is she's doing exposure to shame. And we're increasingly seeing people do that exposure to those kinds of emotions. And of course, you're looking at, at what point do we, also do what we call sort of opposite action in terms of not acting on unjustified shame and not, which usually with abuse situations, of course, that's not justified. So there's pieces where you'd be doing the opposite behavior, but people are increasingly doing exposure to those pieces, and with increasingly that recognition that perhaps it's not habituation as much. We used to think it was all just habituation was what was the active ingredient, and really seeing it much more as modifying your beliefs and really sort of engaging with those problematic thoughts, and recognizing that the feared situation, or that the shame is not justified. So it's that piece too.
Yes, go ahead.
Excuse me, I'm experiencing an enormous amount of anxiety right now because I want to rather make a comment than ask a question. But I do, first of all, want to thank all the presenters this morning so far. I found it incredibly helpful and incredibly useful. I guess because we are in a room full of the probably most important, most active people in dealing with mental health in the municipality, I really want to challenge us to deal with what, at this very moment in the past 2 weeks, is an intense experience of post-traumatic stress occurring within the entire African Nova Scotian community. And I think we need to take the words and concepts and thoughts that we're applying today and give them meaning and action and substance by having the leadership people here come together with the Health Association of African Canadians in our community right now, in the present, to provide some support to the aunts, uncles, cousins, grandparents, extended family, teachers, neighborhoods, neighbors of the people who have been both the victims and the perpetrators of something that has to do with 400 years of trauma. So thank you for letting me say that. Thank you.
Thank you. Well, I'd certainly like to thank our three presenters for what was definitely an excellent presentation. So thank you, Drs. Cohen, Lee Bagley, and Dr. Whitehorn.